Hello, I'm Dr. Marla Shapiro. I'm a past president of the North American Menopause Society, and today I'm joined by Dr. Steve Goldstein. Can you tell our healthcare practitioners who you are and what you do?
So I'm Dr. Stephen Goldstein. I'm a professor of obstetrics and gynecology at the New York University Grossman School of Medicine. I'm a past president of NAMS as well as current president of the International Menopause Society.
So one of the things that often is very difficult for healthcare practitioners is irregular bleeding. Not in postmenopause, because in postmenopause, if it's a year and you're bleeding, you got to work that up. There's not a whole lot of discussion there. But often in and around perimenopause, late perimenopause, menopausal transition, we begin to get irregular bleeding patterns. Which are the ones that really, for us, should raise red flags that say, no, this is just not the perimenopause and hormone irregularity, as opposed to this is more predictive and I don't have to get too concerned?
I'm not sure that you can do that. The first thing I would say is that you never know that the bleed you just got is the last one you're ever going to get. So there's no distinction really between perimenopausal bleeding and true postmenopausal bleeding. They all need to be evaluated. In fact, American College of OB/GYN is very clear about women over 40 who have any abnormal uterine bleeding need to have an evaluation. Having said that,
let's stop there for a minute, because if you have an average 43-year-old who will go 6 weeks without a period, and then she'll have one 4 weeks, and then 6 weeks and 4 weeks, do all those women need to be investigated? Because traditionally we'll see some expected bleeding changes.
I think you've touched on something very interesting, that in perimenopause, to our patients, all the blood that comes out of their vagina is a period.
Right.
To you and I, a menses is a bleed preceded by ovulation. 79% of women that have irregular bleeding in the perimenopause will do so because of dysfunctional anovulatory bleeding, and from the Greek without. But 21% of people will have a structural or anatomic reason like a polyp or hyperplasia, even occasionally a frank carcinoma. I think the important distinction for professionals is to understand there's still a difference between heavy menstrual bleeding, which we used to call menorrhagia, and irregular bleeding, which is metrorrhagia.
Okay.
Patients who bleed heavily every 26, 27, 28 days don't have cancer or hyperplasias. Those things just don't bleed with that kind of regularity to them. Women who bleed irregularly, we begin to become concerned. But you just touched on a very interesting point, which is the graceful way to be perimenopausal is to space it out. I tease my patients and say, no one ever got a D&C or hysterectomy for bleeding less. So the woman who is skipping periods is much less likely to be hyperplastic or malignant. The woman who bleeds twice a month may easily be dysfunctional and anovulatory, but she absolutely mandates evaluation.
So let's talk about that evaluation. Where does it start?
Well, it depends. For many years, people thought that a suction piston biopsy was sufficient.
But you can miss.
Well, the problem is, when you think about it, if you've got a tumor in the breast and you do a needle biopsy, that tumor is going to be the same pretty much throughout that mass. But the uterine cavity, if it doesn't involve enough of the cavity, may miss with a blind endometrial sample. And this became obvious from a study as early as 1995 by Guido, yet it wasn't until 2012 that ACOG went on record as saying a blind sample, if the cancer occupies less than 50% of the surface area, can be fraught with error. So you can still begin with a blind sample, but if it is not hyperplastic or malignant, you're really not done with the evaluation.
So a positive test that gives you a diagnosis is one thing, but a negative test is not necessarily a negative test.
Absolutely. And so what has happened since the last 2.5 decades or so is the use of transvaginal ultrasound. When you have a thin, distinct echo, one of my problems, because I really helped start this whole movement, is that not all uteri lend themselves to a meaningful ultrasound examination. So if you see a distinct thin white line, and ACOG pretty much says for the average patient, 4 millimeters or less should be fine, although understand that there will be some cancers at 3, there will be some other women that have cancers at 4 or at 5, but it's an arbitrary number. And the latest ACOG guidelines do talk about the risk of malignancy for various measurements. But many uteri don't lend themselves to a meaningful measurement. And in our hands, we then go to saline infusion sonohysterography, putting a little fluid in. Remember, fluid enhances sound transmission. The reason ultrasound's a home run in obstetrics, baby's in a bag of water.
Right.
So if you put 5 or 10 cc's into the uterus through a tiny catheter, which expands the cavity and enables you to see the endometrium with microscopic precision, then you can understand if there's a focal process or a global process. A global process deserves a blind sample. A focal process really needs to be done under direct vision. It would be inappropriate, though, not to mention now that they are making these disposable office hysteroscopes so much easier to perform. If you have the equipment and the know-how, a disposable office hysteroscopy should be equivalent with saline infusion sonohysterography. In other words, you need to do direct visualization if you can't see a thin, distinct echo on transvaginal ultrasound.
Okay, so it really does mean that you've got to be a little bit more reticent in terms of, ignoring an irregular pattern without really having a firm diagnosis.
Right, there's no question.
Okay.
The good news is that even in postmenopausal bleeders, only about 5% of those people will have a malignancy. So the likelihood that you're dealing with something really, really bad is low, but not absent.
Not absent, right. And before I let you go, in women where you do a hysterosonogram and they've got a nice lining and you see a 3 millimeter, 4 millimeter, 5 millimeter polyp, can these women be watched or must that polyp be removed? Because we've seen movement in this area, and it's been a frustration, I think, for many practitioners.
If she presented with bleeding and you then diagnose a polyp, I think the standard still would be to remove that polyp. I think, however, often there's a thick endometrial echo on an incidental finding, and if it then diagnoses a polyp that hasn't bled in 5, 10, 15, 20 years, there's overwhelming data that the likelihood that that is malignant is less than 1 in 1,000. And I am not advocating, nor do we advocate, taking polyps out of patients that are diagnosed incidentally that have not bled yet. And in fact, if that's not comforting to patients, because I have some who say I'm always the 1 in 1,000, there was good evidence that if endometrial cancer is picked up and treated within 8 weeks of the bleeding episode, the 5-year survival and prognosis is every bit as good as if you were fortunate enough to pick that occasional case up incidentally. So I tell my patients who have a diagnosed endometrial polyp that has not bled, if they have any bleeding, even brown discharge, they must call me. But absent bleeding, we are not removing those polyps.
Very reassuring. Thank you so much for joining us today.
Thank you for having me.